Hi, good afternoon, everyone. Welcome to our first discussion for ST 115, Unit 1. Um, Happy Halloween. All right. So let's get into it. A little bit about me, if you haven't heard of me before. I'm relatively new to Herzing. I started in January of this year, so I've got, a couple months under my belt, but I really enjoy teaching online for Herzing, but I've been teaching since 2012 throughout a couple different colleges. That we have a couple local programs where I live in West Virginia. So I've taught at both of my local programs. And I became a surge tech, certified surge tech in 2008. And just recently, within the last couple of years, got my bachelor's. I went back for my bachelor's degree at West Virginia University at Parkersburg. So this was one of our labs over here teaching different surgical procedures. And these are my two kids that they're actually a little bit older than that now, but I do have two kids, 10 and 9, and we have a lot of fun. So every week I try to give you, a brief update as to what you should be doing this week. You can obviously look at it in your calendar or your syllabus, however you want to look at it, but just to give you a heads up that this week you do have a couple assignments. This one here is worth 50 points, so definitely make sure you get those in. Homework is such a big part of your grade in this quarter, so really make sure you get those in, and you will do well if you do your homework, honestly. And as you already saw, or probably have seen, I'm assuming most of you, it looks like, have already navigated the course some. You do have a discussion post that's due each Wednesday, your first discussion, and you need to respond to a peer by Sunday. So when I'm grading these discussion posts, what typically I think students get the most points taken off for will be not citing your sources in APA format. Every discussion post needs a citation of some sort, and not going back and responding to your peer. Those are the things that I typically take the most points off for. So don't forget those things. And if you have questions on how to cite in APA format, if you're not familiar with that, let me know. There's also resources in the library tab within your Canvas. I said Schoology before. I meant Canvas, sorry. I use two different things for two different jobs. So this week we're going to be talking about healthcare facilities, different laws, ethics, and documentation as it relates to you as a surge tech, what your role would be in those things, and how it relates to the surgical environment. So I just have this brief video of what is it to be a surge tech. I would assume that most of you have not stepped foot in an OR. Maybe you have. So a lot of times as a new surge tech student, most of the time they have not been in an OR, or at least not one that they remember. Maybe they were a patient, whatever, but don't really remember. We do have some students that are already practicing as like sterile processing techs that may be a little more familiar with what goes on inside of an OR, but I like this video. I would highly recommend checking out this YouTube channel called Surgical Counts. He hasn't in a while, but he puts out a lot of good videos on just different things that you'll encounter as a surge tech, as a student, on the job, instruments, lots of things. So I do reference them sometimes just to give you a better visual. So
what is a surgical technologist? How do I become one? And what's it like working in the field? Well, these are the questions I'll attempt to answer in this video series.
Don't do that.
Surgical superhero?
No, Wonder Woman.
Just like Boki An, the real-life scrub nurse on Grey's Anatomy.
Thank you, Boki.
Surgical technologists play a very important role in making sure surgeries proceed the way they should and that the patient has a positive outcome. So what's it like being a surgical tech? Well, I've invited some friends to help explain it.
A surgical technologist is someone who plays a very important role in a surgical team.
A surge tech is, in my opinion, it's the backbone of the OR.
We're really the doctor's right hand.
In the operating room, people from many different specialties come together to make the surgery a success. Take a look at this picture of a typical operating room. Around the periphery, you have the OR nurse, the anesthesia provider, maybe an x-ray tech or a sales rep for medical devices. But right up here, scrubbed in right next to the patient, this is where you'll find the surgeon and the surgical technologist. We're so close to the action that we often have our hands on and sometimes even in the patient.
I loved it. My first one, I almost passed out. I was so nauseous.
Not only do you pass instruments or hand what the surgeon may need, sometimes he needs another extra set of hands.
Sometimes you're in there with your arms and you're kind of retracting, so that's really neat.
You might be a lot more involved than you think you would be versus just passing instruments the whole time.
So what exactly does a surgical technologist do?
It's a hard question to answer because there's not just one thing that we do.
Cool things.
In the operating room, the surgical technologist has two main roles. Number one, we're in charge of maintaining the sterility of the surgical field.
We maintain sterility at all costs. We protect the patient. The patient comes first.
Items used during surgery must be sterile. This means there cannot be any germs on any surgical instruments or devices, on the drapes that cover the patient, or on the gowns or gloves worn by the surgical team. Because if any germs get on any of these items, they could end up in the patient and cause a potentially severe infection. And this job is difficult because you can't see germs. You can't tell just by looking whether something is contaminated. So the surgical technologist needs to make very precise movements, ensuring that sterile items don't accidentally touch something that isn't sterile. And they must maintain constant vigilance to make sure that nobody else accidentally contaminates the sterile field.
You're a mind reader. You're anticipating every move that everybody in the room makes the entire time.
And all this must be done while they fill their second main role, which is to assist the surgeon during the surgery. So what does all this look like?
So first in the morning, we'll wipe everything down.
Before the surgeries, we are helping position the patient, getting things ready for the surgery.
Open up stuff, getting the instruments ready.
Create a sterile field, which is the base to surgery because you need somewhere to have all your instruments and everything.
Why that popped out?
We'll start setting up a sterile field, preparing the table with all the instrumentation, looking at preference cards, making sure we have everything so that the surgery can be as quick as possible.
We make sure that we do counts.
1, 2, 3, 4.
Passing instruments. We are holding retractors.
We pass instruments.
You just have to know what the surgeon wants right there and then and just help pass instruments.
Gown and glove the doctor, help the nurses.
And then after the surgery, kind of like the cleanup portion of it, helping move the patient back to the bed to get them out of the OR. And we are basically, it's like a constant repeat, but we're always doing something.
Back in the day, nurses were given some extra training and they were the ones who filled the role of assisting the surgeon. But over the years, the job came to require more specialized knowledge and skills that weren't completely covered during a typical nursing program. So the role of surgical technologists split off from nursing, and today they are two very different jobs. Surgical technologists focus on setting up and maintaining the sterile field, knowing the procedure so they can anticipate what instrument the surgeon will need next without her having to ask for it, keeping track of all the instruments and supplies because we don't want to lose anything in the patient, and generally keeping the surgical field tidy. In the OR, nurses still play a very important role. They're responsible for charting, recording any information during the procedure, helping position the patient before the operation, and helping to transfer them out of the OR after the operation, and otherwise acting as the manager of the OR. But during the procedure itself, they are usually away from the patient. Is surgical technology like any other job out there?
You definitely want to get used to smelling horrible things in the OR. Definitely get used to that.
I think out of everything though, I didn't realize that you're doing a bowel resection for cancer. And I haven't eaten in 17 hours. And you don't realize how you can be thinking about food in that time period.
So yeah, it gets a little weird at times.
You'll get out what you put into it. If you thinking it's a fly-by-night kind of thing, and it's probably not for you. But if you're willing to put the time, energy, effort into doing it, it is beyond rewarding. It is beyond your imagination. For me, it was.
So if any of this sounds interesting to you and you're thinking about becoming a surgical technologist, please watch the next few videos as I describe what you need to do to get the job, what it's like going to school for surgical technology, and what it's like to do the job itself. But for now, I'll leave you with this quote. It's what surgical technology instructor Mel Angelisanti tells their class.
This is the most unknown career in healthcare. You will have some of the most remarkable experiences known to human beings in medicine.
So hopefully that gives you a little bit more of an insight. There's a lot of great advice in there, and hopefully some encouragement. It can be daunting, especially as a new Surg Tech student, to go into such a field. It is a lot of work, but like they said, you know, you'll get out of it what you put into it. So if you're willing to put in the effort and learn what you need to and do what you need to do at clinicals, you'll succeed, honestly. There you go. Sorry about that. So let's move on. How do I know what I'm allowed to do as a Surg Tech? This is our next question here. Throughout each week, we're going to discuss different things at the Surg Tech, the role of the Surg Tech, we could say. But how do you know what your role is, what you're allowed to do while you're on the job? So there are a lot of laws and regulations that we have to follow to keep the patient safe and to keep yourself safe as well. So one of them, the thing that gives you the right to practice as a Surg Tech, will be the National Board of Surgical Technology and Surgical Assisting. This is one of two, really, boards that certify you to become a certified Surg Tech. The other one is the NCCT, which becomes you'll become a TS-C, a Tech and Surgery Certified. Both end up with a certification. So this is a company essentially that you will take your certification exam through. Either you pass or fail. So it is a type of certification, not a licensure or registration. So Surg Techs are not licensed or registered like a registered nurse. That is different. So as of right now, we are certified, and not all states require certification. That is something a lot are working toward, some sort of certification. It may be required at your facility though, so sometimes different facilities have different rules or expectations as to what a Surg Tech requires. So there are three main groups of laws, three types of laws: federal, state, and civil. Those are the main ones, and these kind of like fall underneath all of those. You have federal laws are going to be things that are the same no matter where you go throughout the United States. There are certain things that you can or cannot do throughout the United States, no matter where you go. So for example, you cannot make an incision as a surgical technologist. Now, if you go on for more training to become like a first assistant, a certified first assistant, that's different. That requires separate training, so therefore you kind of fall under a different set of laws. So as a Surg Tech though, really the general rule is you cannot alter tissue. So we can't be cutting things. We're not, we don't suture. That's not usually within our realm, our scope of practice. Some state laws may be different. You could go state to state. If you live on a state line, you have to be careful. I live on a state line between Ohio and West Virginia. So some facilities let you do this, some, you know, so it's kind of, you just have to be careful. And anytime you get a job as a Surg Tech, you really want to read up on your facility's scope of practice, what they allow you to do. You never want to take anyone's word for it. It could get you in some trouble. You can't, even if your best friend works there and they're like, yeah, you can do this, and you do it and you get in trouble for it because you really weren't allowed to. That's on you, not them. So you could really, you could hurt a patient, or you could lose your job by not being aware of what these laws say you can and cannot do. So it is important. I know it's not the most exciting topic to talk about laws when you really just want to talk about surgery, but you have to understand what you can and cannot do. So along with laws, we have to talk about negligence. So negligence, in a nutshell, the term negligence means it's either you are doing something or you don't do something that someone in your position would know to do or not do. So for example, once you complete your training as a surge tech, that means you should have a basic understanding of what's required of you. Now, if you go into the workforce and you either omit something that you should do or commit something that you shouldn't, that you've been trained differently for, and you do it anyway, that's negligence. There are a lot of things that could happen here under that umbrella of negligence. Retain foreign objects, leaving behind a sponge. Okay, you knew as a surge tech that you have to account for all those items. And either you miscounted or you were in a hurry, maybe initial count was wrong. There's a lot of things that could theoretically happen. Either way, it still comes back on you because that's your job to making sure all items are accounted for. Burns, there are a lot of ways, and I don't think, and you'll learn throughout this quarter, there are a lot of ways patients or yourself could get burned in surgery. And patients don't realize this either. The burn risk, the fire risk is very high in surgery. Sorry if that just got loud. My air just kicked on. Heat, I should say. Finally turned my heat on. So burns are a big concern for patients. We have to be very careful with heat sources. Falls, we don't have to worry so much about falls unless we're talking about transferring patients from bed to bed. Typically, our patients don't walk into the OR or walk out. More often than not, right? They're on the stretcher. So look through some of these, and we'll talk about each of these as time goes on, but these are all considered negligence. So like medication error, maybe you didn't label something. You didn't label your drugs on your back table. By law, you have to label your meds. And if you didn't do it and caused an error, which really this one could kill a patient, so that you could be criminally charged as a surgical technologist. Okay. So a lot of people think, oh, the surgeon is in charge of the OR, which, in some cases they are. They're the captain of the ship is the legal doctrine for that. But you are still responsible for what you know to do, what you know is right or wrong. Okay. Along with this term is a tort. A tort is something, an action that caused physical or psychological harm to our patient, really. We're concerned with here. So a couple categories of torts here are negligent torts, intentional, or medical malpractice. Malpractice and negligence kind of go hand in hand. They're pretty synonymous. So malpractice is an unreasonable lack of skill by a professional. Once you graduate as a surge tech, that should show that you meet the minimum level of competence. You have achieved that standard that we've set, that you've reached all those goals, learned all the things. But if you go out and practice and you're not doing those things that you've learned, it's technically malpractice. Okay. So negligence is, like I said before, failure to do something a prudent person or someone that you has been trained would or wouldn't do. Now, intentional is purposeful. You're trying to cause harm. More often than not, in surgery, this is not the one that we would get charged with unless you're just a hateful person and set out to hurt somebody. More often than not, it's negligence. Some other key terms related to tort, assault and battery, these are going to be intentional, really. Usually, I guess I should say usually, not always. So battery, a lot of people get these two confused, right? Assault and battery. Like battery is if I took a bat, a literal bat, and hit you with it, right? That's how I remember the difference. Because battery is the physical attack. Assault, however, is just saying, I'm going to hurt you. I'm going to hit you with my bat. Just saying a threat. Now, battery is the actual doing. Now, notice here under battery, performing surgery on someone without their consent is considered battery. So that means if the surgeon and the circulator don't get all the forms signed, they're called informed consent signs, from that patient who is conscious, awake, knows what they're signing, and we do surgery on that patient, that is considered battery, and we could legally be charged with battery. So you always want to double check your paperwork and make sure the patient has signed those consent forms. Slander is verbal, defamation, and libel is written. So defamation is like trying to degrade your reputation, saying bad things about you. It's a little harder to take these to court. You have to have a lot of evidence, especially you would know this if you watched the Johnny Depp trial, right? That's what this was about, libel, defamation of character. You have to have a lot of evidence to prove these things. But really what you need to be concerned with is not going out and bad-mouthing, let's say, a surgeon. You may not like this surgeon, but that doesn't mean you can go write about it on Facebook, okay? So you can't say it, you can't write it if it's going to hurt their reputation. All right, so we talked about the NBSTSA. That was the company that your certification test is through. That's your certifying body. The other common company, I guess you could say, is the Association of Surgical Technologists. This company works closely with the NBSTSA in that they put out your continuing education units, your CEUs, we call them, that you have to have, I think it's, forget what it is. They just changed it. I think it's like 30 every 2 years, maybe 30 CEUs, I think. I just went from the 4-year cycle to the 2 years, so I think it's 30. But you have to have so many continuing education units to continue your certification, to keep your certification that you just tested for. If you let your certification expire, you have to retest, which can be a pain. You don't want to have to do that, and it's expensive. So the AST holds those CEUs for you. You don't have a choice, to be honest with you. So they hold your CEUs so you can maintain your certification. CEUs are important. You want to continue your education because surgery and healthcare in general is always changing. There's always new studies or new equipment that comes out that you have to stay on top of. It's a rapidly changing field. So you have to want to learn if you want to be a surgeon tech. The AST's motto, you'll see here, is, this is pronounced, Ager Primo, which means the patient first. So this should be your motto as a surgical technologist, patient first. If you remember that every time you go to work, it makes things a lot easier. No matter the drama that goes on in a hospital or how hard things can be, you're there for the patient, not to be there with your best friend or get involved in something else. Patient first, okay? A lot of people, once they get in this job, they get kind of complacent and they forget that. They forget why they're there. So make that your why you're in surgery. A couple other fun Latin terms that really no one just says in normal conversation. They're hard to pronounce. That pertain to laws is respondeat superior, which means let the master respond or answer. So really what that means is you as a professional are responsible for your actions. What you do in surgery, you are a professional, you are responsible. Okay. This next one, res ipsa loquitur. Maybe I'm saying that right. I think that sounds right. It means the thing that speaks for itself. This has been on certification exams. It wasn't that long ago. One of my students came back and said, what's this mean? I said, we talked about it in like chapter 2. Okay, res ipsa loquitur, the thing that speaks for itself. Something that is very obvious that is negligence. For example, if you leave a sponge inside of a patient, it's very obvious when you go put up an x-ray, you see the sponge, right? It's very obvious what happened. Negligence, you left something behind. You didn't count correctly. So this would be the law term related to that act of negligence. And this last one here, primum non nocere, means first, do no harm. This is another like guiding ethical principle, you could say, for healthcare workers in general. Especially, doctors will always say, do no harm. That's true to us too, surge techs. We want to make sure, A, we're putting the patient first, and we do that by not doing harm. So along with laws, regulations, we have to talk about risk management. So there, in each facility is usually a department, maybe in like human resources, whatever, that is responsible for risk management throughout the facility. Their goal is to prevent harm to our patients and staff throughout the entire facility. So if something happens to a patient that, caused harm to that patient, you have to do an incident report. That incident report goes to risk management. They're going to review it and see were all the safety measures followed. Could there be improvements? Do we need to redo staff training? What can be changed to make sure that incident doesn't happen again? So that is risk management. Along with risk management, like I said, you have to have documentation. A lot of different types of documentation. Everything in healthcare is documented, I'm sure you're aware of. So it's required in all areas of medical practice. Doesn't matter the healthcare facility. It could be outpatient, hospital, doesn't matter. So that's all part of what the Joint Commission sets as their standards. The Joint Commission, if you're not familiar, is the company that accredits healthcare facilities, all healthcare facilities, which means each of this Joint Commission sets standards, minimum things that these facilities have to be doing to stay accredited, which means they're meeting the minimum things that they have to do. If you ever go to a healthcare facility that is not accredited, I would turn around and walk away, okay? There's a reason why they didn't meet their accreditation standards. Something happened, they were given a chance to probably correct it and didn't, their accreditation gets taken away. So it just means that the facility or the staff isn't putting out the effort to make sure things are safe, things are up to code. That's what Joint Commission does. So you'll hear people say the Joint Commission is coming and everyone like runs scared because they're going to be, out with their notepads, looking at every nook and cranny to make sure everything's up to code, standards are set. Another type of documentation is HIPAA. This is the correct acronym for HIPAA, 2 A's, 1 P. Stands for the Health Insurance Portability and Accountability Act of 1996. This is what gives patients their privacy, the right to privacy. You can't go out and say, my neighbor down the street just had a hysterectomy. You can't announce that on Facebook, right? That's part of HIPAA. Those are HIPAA laws. So you as a surge tech are responsible for adhering to those things. Common types of documentation. We've talked about a few. I mentioned this one. Informed consent is what the patient has to sign in order to have a procedure done. Medical records. When a patient comes to surgery, so many documents occur, not just the informed consent, but there's a special intraoperative record that goes in their main record, okay? Anesthesia keeps track of all their stuff separate that goes in the main record. So a lot of things are documented. Every little thing really needs to be, because if something comes back wrong, or maybe the patient comes back with, let's say, an infection, an SSI, they're going to pull the record. They're going to look at, maybe we put in implants. Maybe we charge for this implant. You could look back and see with the company, maybe was there something wrong with the implant? Maybe something was sterilized wrong. Anything that gets sterilized, there's a record of. So they can pull those things. Anytime there's a specimen that gets sent to pathology, there's a special record for that as well. So a lot of documentation. As a surge tech, you're not going to be the one on the computer. You're going to be relaying information to the circulator that will put it in the record. So it is a joint effort. So a little bit more about this informed consent. It is the legal document that's signed before surgery by the patient. A lot of things have to be present in this informed consent for it to be valid or legal. If you have a Spanish-speaking patient and this informed consent's being explained to them in English and they don't understand what's happening, what's being said to them, They cannot legally sign that document. You have to find a translator, someone that can explain it to them in their language, right? So you may have to get a translator. A lot of facilities typically, I think, have one on staff or could get one. Before they sign this informed consent, they also have to describe what's going to happen. They have to explain risks, benefits, and alternatives. They're supposed to, surgeons especially, are supposed to give them other options if there are any. Sometimes I know there may not be, but potential outcomes, potential risks, there's always a risk of, let's say, damage to certain nerves or even death, right? I mean, patients have to understand that and accept the procedure, then they can sign it. If this patient is, for example, let's say mentally incapacitated, they don't understand what's being said to them and they have a legal guardian, the legal guardian can sign it, but they have to have the proper paperwork for that. So along with paperwork, informed consent, risk management especially, are something called sentinel events, also called an adverse event. So not good. These are not great. Okay. A sentinel event is something that, an event in surgery that results in harm or death to the patient or severe temporary harm. So these are it's not just, oh, I dropped a hemostat or maybe my glove got contaminated. That's not what we're talking about here. This is like, let's say we accidentally ignited the Bovie, the electric pencil, on the patient, the drapes caught on fire and caused third-degree burns. That is a sentinel event because it causes more than likely permanent harm and severe damage. So that special event right there requires special paperwork that you have to submit. If you are a part of that in surgery, you have to help submit that. And then it also goes to this institute, goes to your risk management, especially if it's related to medical devices. They'll look into those things to see if, maybe the device isn't safe. They'll do a lot of things here, this ECRI Institute. So how do you develop an incident report or a sentinel event? So we just described incident or a sentinel event. An incident report could be, let's say the surgeon got really mad at you during the surgery for whatever reason and threw an instrument at you and hit you. You can write them up for that. That's an incident report. So how do you go about documenting those things? You need to include the facts, not your opinions, but the facts. Who, what, when, where, how, right? That's what you need to put. Who was involved, where, when, how did it happen, what was going on at the time. Guidelines here just state the facts. Again, no opinions, even if your emotions are running high because you got mad or something, or you were hurt, right? But you want to do it as soon as possible. Use first person like you're saying it. You're writing it in your own language. Take your time, but do it soon. That way you don't forget the events. You don't want to wait 3 weeks and then do it, because then it's not going to be quite as fresh in your mind or valid. Don't become intimidated. Don't be afraid of retaliation. Really anymore, they're really starting to crack down on this type of behavior, especially when it's related to surgeons or workplace violence. I know you've probably heard horror stories about surgeons who are just terrible to work for, mean, degrading, whatever. They really are trying to crack down on that because they've realized that it's harmful to the patient as well. Patients don't have as good of outcomes when the team in the OR is not unified. So if there's something going on, it could definitely affect patient outcome. We don't want that. So always also submit to your OR director, let them know what happened. So this HIPAA is, we talked about, making sure the patient's information is private. You don't want to share any of these things. One that I will especially point out to you is photographs. And I point this out because I've seen students, remember, I've been teaching for 10 years. I've seen a lot of things. Students who take their phones in the OR, which is a no-no, who like to take selfies. They're like, hey, look at me, I'm cool, I'm in the OR now. But in the background of the picture might be the patient's name written on a whiteboard, and they don't realize it. they post it on Facebook, that's a violation of HIPAA. You, even as a student, can be held liable for that in a court of law. So be very careful. Don't take your phone in the OR for one. Don't even be posting on Facebook like, hey, I just got to do this really cool craniotomy on this patient. Maybe you work in a small town. How many craniotomies do you think are done a day? If it can be drawn back to a patient, if there's enough identifiers that could say this is who this is referring to, you can become liable for that. So be very careful with what you say and what you post. Okay, so that kind of wraps up this discussion for Unit 1. If you have any questions, please feel free to reach out to me. I try to get back to you as soon as I can. During the week, it's mludwig at herzing.edu. I do have office hours today, 1 to 3. I'm on the East Coast, so Eastern Standard Time, or by appointment if that doesn't work for you. But yeah, just reach out to me. I'm pretty open to questions. So have a great week.